And
Hello, sir.
Good evening, respected faculty members, residents, and presenters. Welcome to the Jiaps Abhigyan episode number 9. Uh, we had previous 8 episodes who went successfully, and today we have two moderators, Dr. Basant Kumar, professor and head pediatric surgery from SGPGI, and Dr. Rahul Gupta from SMS Jaipur. They will be moderating the sessions, and we have three papers. Uh, Titles we have already shared. They are the association of sacral index ratios and sacral curvature with different types of male ARMs. Presenters are Dr. Rohit Lal and Etal, and another study is navigating the ergonomic challenges in pediatric laparoscopy by Dr. Sugan Chadda. And third one is systematic review and meta-analysis comparing the outcomes of reduction versus non-reduction pyeloplasty in children. So before we hand over the podium to moderators, I will request our editor-in-chief, sir, to kindly give introductory speech. Sir, please.
Yeah, thank you, Vijay, for starting the meeting. And once again, I thank all authors of the manuscript who has been wholeheartedly supporting JIAPS with record number of manuscripts already received, which is, I think, 235 plus as of now. It's a record by itself. When I took over, it was less than 200 in entire year. So this year it is going to be double. Along with that, this work would not have been possible without the help of all the members of IAPS who are reviewing these manuscripts left, right, and center. Some of them are reviewing maybe, maybe 30, 40, 50 in a year, which is a big number. And the entire editorial team, editorial secretaries, section editors, Vijay, Manoj, and now the Rohit is also going to help. Rohit last name is different, not Rohit Lal, but Rohit, I forget, Gopinath. Rohit Gopinath is also going to help us in initial assessment. As work is increasing, we need to expand the editorial board, not board, but the working people actively, and that is what we are doing. Along with this, which I want all IAPS member to think over, it's a high time now we separate out case reports from the main journal. We can decide whatever name, what is going to happen as far as the guidelines are concerned. Our ratio of case reports and versus original reports should be about 20%. So as of now, we are publishing about 10 to 15 or 15 to 18 original articles, which includes review articles, systemic analysis, award articles. All this, if we consider in a bunch, then it will be about 15 to 18. So we will not be able to take more than 5 to 6 case report per journal, per issue. Now, if that is there, we will have huge backlog of case reports. And if we cut down, then it is again a lot of good articles we may have to deny the publication in JIAPS. So instead of that, I think the best thing would be to get the case report journal separately. We will have to collectively decide how to support. But personally, I feel that case report should have author publication charges or article processing charge. So per article, if it is a case report which is about 1,000 to 1,500 words, I think something like 6, 7, 8,000 per manuscript. If we charge, it will be self-sustaining. We will be able to accommodate more articles. I will like this to be discussed in the GBM and get the approval and then we can start working towards that. So maybe in another 6 months, 1 year time, we will have case report journal. It will soon get index with regular indexing bodies. All the indexing may not happen immediately, but then most of the NMC requirement can be still fulfilled if it is indexed with basic stuff. With these words, I will request our moderators to take over. But before we take over, we need to decide uh, the article. As of now, it is, I think, first article is Rohit. Ramesh, it is all right, no, Ramesh Babu? Because
Yeah,
he,
I want to go first. I'm I'm
okay.
I'm sharing the screen, right or not?
Yeah, no, so right now it is Rohit ka stuff is there. Rohit,
No,
you
I
go
want to.
second and Sugan can go third. So I request Rohit to discontinue his presentation. And Hira was supposed to present the article which Ramesh is going to present, Dr. Ramesh Babu, but somehow Hira is not able to join, and Dr. Ramesh Babu has agreed to present this particular article. But before Ramesh Babu, I will request Dr. Basant and Dr. Rahul to take over with the proceedings.
Yeah. Uh, Thank you, sir. Good evening, everyone. I'm Dr. Basant. That's a very nice talk given by our Rasik sir, Chief Editor, JIPS. Sir, I am with you with all your thoughts, and definitely we need some other journal too with IAPS. And today we have selected three articles, and they are unique. All are very good. And but today I want to I want Rahul, Professor Rahul. He will lead me. Okay, Rahul,
Thank
up
you,
to
sir.
you.
Thank you, sir. Sir, Dr. Ramesh Babu will be presenting the systemic review and meta-analysis and the outcomes of reduction versus non-reduction pyeloplasty in children from Department of Pediatric Urology, Sri Ramachandra Institute of Higher Education and Research, Chennai. First of all, I will like to congratulate the authors for being the first ones for publishing this review, and it is the first one in the world. And sir, you can start, sir.
Are you able to see my screen?
We can see your screen.
So are the slides moving?
Yeah, it is, they are moving.
Okay, thank you. So this is supposed to be Dr. Hira's presentation, and she made the entire PowerPoint, and suddenly some family emergency came, and then some grandfather has passed away, so she has to leave. So that is why I am here. So it's a pleasure to join this JAPS Abhigyan initiative. The basic the article is about this research question. Does reducing the renal pelvis during pyeloplasty have a better clinical outcome compared to not reducing the pyeloplasty? That is the research question. The reason we asked ourselves this question is we have not been reducing the pelvis, particularly the laparoscopic surgeons and robotic surgeons. Due to initially we started doing it because we felt that it takes a lot of time to reduce. Then we felt that the things were moving in the right direction even without reduction. Then we continue not reducing the pelvis. So we just wanted to see what happens. So already several papers are there which describe laparoscopic and robotic pyeloplasties without any reduction on the uh, on the pelvis. But have there been any publications, and is there any evidence to support it to see what happens in these patients? So we wanted to assess the drainage, pelvis size, renal function recovery, and then compare the failure rates between the reduction and non-reduction pyeloplasties. So I will not go into the details of this, the complicated Prisma flow chart. Basically, the process is we filter the articles over the 20 years, and we find only the articles which compare reduction and non-reduction in the same series. So that is how we can derive at an odds ratio. So that reduces our articles to only 5 articles. So if we really receive all articles, some saying reduction, some saying non-reduction, then there is no problem. We'll have hundreds and thousands of articles. But we've selected only the 5 articles which included only in one single study they compared both modalities. So that included 3 randomized controlled trials and 2 prospective non-randomized studies. So we used the Meta Excel software for the pooled proportions and Revman software for odds ratio plot, also to get the heterogeneity. And the pyeloplasty failure is basically a redo pyeloplasty. So that is when we call something a failure. When somebody needs a redo pyeloplasty, we call it a failure. Now, the biggest problem is, in addition to having a small number of papers, only 5 papers are there. If you look at the number of cases they have reported, they have compared. I want you to focus on. Sorry, this is moving. So there are 5 studies, total 168 patients. 4 studies were comparing open versus open, reduction pyeloplasty with open non-reduction pyeloplasty, and 1 study compared open reduction pyeloplasty versus laparoscopic non-reduction pyeloplasty. Now, if you look here, this particular study, first study is by our own Inono Yoshu. So she published it in JIAPS in 2022. So that is comparing 21 patients in reduction limb and 21 patients in non-reduction limb. If you look at other studies, they are all much lesser number. This is the largest, basically. Even 21 is the biggest here. 21 plus 21 is 42. You should look at it that way. But here they are comparing 10 and 10, 20 and 20, 20 and 20, and 12 and 12. So this is the problem we are facing here. So each, although there are only 5 papers, each papers are comparing only a small number of patients. Now, when you look at the failure rate of pyeloplasties, it is like 5%. So to look at even 5%, get 1 patient, you need at least 20 cases. So that is again, very difficult. 2 of the studies are having less than 20 patients. So you can hardly say that, they had a failure or no failure, because these people are saying all success, 10 out of 10, 21 out of 21. So like that. So, the next patient may be failing. So again, this is the problems and handicaps of systematic reviews and meta-analysis, because the evidence you build is based on the quality of the substance you're having. And here the quality is not great. So we have to take it with a pinch of salt. So out of the 83 patients, 2 had a failure in the reduction pyeloplasty. In the non-reduction pyeloplasty, out of 85, 3 had a failure. But if you look at, in more carefully, only 1 study reported any failure. So all the other studies have got 0 failure, 0 failure, 0 failure. So the entire the meta-analysis based on 1 paper. So this is where the problem of this meta-analysis is. Basically, we can consider this as a duplication of this particular study, because all other studies are not showing any failures. Having said that, we can also put it the other way around. 4 studies have not found any difference between reduction and non-reduction. So that it's also a finding. You can argue it that way also. But basically, this is the forest plot, which says that there is no big difference between reduction and non-reduction pyeloplasty. The p-value is 0.6. So although there's a little bit of favoring towards the reduction, it's not a big difference. Now, one more thing I want you to see. I'm going back here. So the AP diameter of the patients who they reduced and then non-reduction. Here there is only 1 study where they have looked at some big numbers of AP diameter. So the AP diameter, 1 study has not given any AP diameter, and then so there is a lot of variations in the selection of the AP diameter. Some of them have actually non-reduced to 24 millimeter and then still said that it works. So they have actually selected a easier patient. So these are all the handicaps. So overall, the outcomes are reduction pyeloplasty patients showed a better early drainage, in the sense that if you do a renogram or an ultrasound within 6 months, the reduction pyeloplasty people had a better the pelvis size as well as the drainage pattern. But when you wait for 1 year and then repeat the ultrasound and then the renogram, the other good limb, the non-reduction pyeloplasty also catches up with them. That means, over a period of time, there is a reduction in size of the pelvis. Now, what are the concerns with reduction pyeloplasty? There's a risk of leak due to long suture line, longer duration of surgery, risk of damaging calyces if you inadvertently enter into all that. The most important thing is the tension in the anastomosis between a reduced pelvis and a spatulated ureter. Sometimes we have around 3 to 4 centimeters of stricture, and then we keep on spatulating the ureter, and then we keep on reducing the pelvis, and then they don't come together, and there's a lot of tension. So, I mean, this is the reasons why people say that they went. So, reduction pyeloplasty definitely has got an early advantage, but in the long run, non-reduction pyeloplasty also has got a equal outcomes. So, only one study which has got pelvis more than 50 millimeters showed a non-reduction pyeloplasty failure, and the functional outcomes are similar. So, this meta-analysis showed that there is no significant difference in failure rate. Maybe reduction can be advised for pelvis more than 50 millimeter, and then maybe NRP is safe for more than 40 millimeters. But these are speculations; these are not based on this study. Early imaging may overestimate a NRP failure. So the strengths and limitations I've already told you as I went through the study. This is the first meta-analysis comparing RP and NRP. So it is a Prisma complaint, small sample size, only one study with the failures, heterogeneous, success definitions. I mean, this is important. Although, some people say that, failure means only failure needing a recurrent or repeat operation. Is there a better definition for failure? Because when you don't define the failure, then how can you claim what is a failure? Is it a persistent dilatation of failure? If a persistent obstructed curve failure, or if the function reduces that failure? If you decide not to operate on some of the patients, can you call them a success, although there is no improvement? So these are all like some definition problems. So basically, based on this meta-analysis, we say that non-reduction pyeloplasty is safe in most children. Consider reduction of the pelvis if the pelvis is more than 50 millimeter. Standard definitions are needed and larger RCTs are needed. Now, having said that, as a corollary, at the same time when this got published in JAPS, we published another paper in Journal of Pediatric Endoscopic Surgery. So this is out of these 5 papers, none of them is our data. So we thought we look at our paid data. And our data is only non-reduction because we don't reduce the pelvis. So what we thought is we look at the outcomes of not reducing the renal pelvis during laparoscopic pyeloplasty. So again, we put them into 2 groups, pelvis more than 40 millimeter or pelvis less than 40 millimeter. And the findings were exactly like at 6 months, in the large pelvis group, there's a reduction and is at 1 year there is further reduction. Both groups show the significant reduction. Interestingly, in the large pelvis group, there is a 60% improvement in pelvis because they started at 60, 50 millimeters, and even without reduction, they come down very significantly. Whereas when you start at a 24 millimeter, 20 millimeter, they don't come down as much as you think, even without reduction. So without reduction, the pelvis size doesn't come down much, but the split renal function improves. The recurrence rate is not significantly different. So this paper also concluded that laparoscopic pyeloplasty without reduction is safe, even in large renal pelvis more than 40. So maybe in a pelvis more than 50 or 60 millimeter, one should start reducing. But if the pelvis is less than 40, we can continue to do a non-reduction pyeloplasty. So that's about it. Thank you. If there are any questions, we are happy to discuss.
So very nicely presented, sir. So there are a few questions in the chat box.
Yeah,
Dr.
please.
Vikesh is asking, how do we define a reduction? And is there any significance of the size of the pelvis in taking such a decision of non-reduction, like large giant POJ or maybe a 4 to 5 centimeter pelvis?
That he
As I
already
said,
answered.
yeah, as I said, there are a lot of friends who have stuck to reduction pyeloplasty, they reduce a 25 millimeter pelvis and end up in a tension in the anastomosis. So I would say that, it's okay not to reduce a small pelvis, but if the pelvis is more than 50 millimeter or 60 millimeter, reduce it. And if there's a mass, definitely reduce it.
And how do we define reduction, Babu sir? I mean, how much excision of the pelvis you will call it a reduction?
This is very subjective thing,
Hmm.
and it varies according to the size of that, various the way people think. Also, how you reduce it also matters. Some people make that V-shaped cut. Some people just make a horizontal cut, and some people do further reduction after the anastomosis is completed. So it is very subjective. But what I suggest is, particularly when you're doing minimally invasive surgery, do not be over enthusiastic about reduction. Even if you reduce it by 50%, it is more than enough because you have relieved the obstruction. If you enter into calyx or if you create a tension in the anastomosis, that's going to cause a recurrence. So even a 50% reduction of the pelvis is more than enough than causing a tension in the anastomosis. That's my opinion.
Sir, according to you, what is the likely cause for better drainage and reduction in pelvic size in early follow-up, while in late
It
follow-up, it was not there,
Yeah,
sir?
the we are depending mostly on the renogram. The renogram washout is slightly better when there is a volume dependent drainage. It gets better. Also, the parents get happy within 6 months that there's a good improvement in pelvis size. But when we wait for 1 year, this change is not seen. Even without reduction, we are able to achieve the same results. So, it's a matter of counseling upfront that everything will be all right by 1 year, so you please wait. And by that time, usually, this pelvis under gets molded, the cortex increases, and the drainage also gets better when you do everything at 1 year.
Yeah, Ramesh Babu sir, can I ask?
Yeah. Yes, please.
Yeah, actually, that's very nice article. And coming to the article, then you have already said if it is more than 50 mm size, we can go for reduction. We can go for reduction. It's not necessary. And there is a lot of problem in reduction by laparoscopy or robotic for defining. But what is your, you have written in this article, there is a lot of things, I'm not discussing that. What you think? Personally, you think how we should follow up? First, my first question is, what is long-term follow-up? How much time you need to reduce the size or compare the early versus late result? And other is, if you are not reducing the pelvis, uh, in compared to the pelvis who has 30 mm diameter and who has 50 mm diameter, how much time it will take to give similar result, and how will you evaluate the results? It is the thickness of cortical, it is cortical thickness, or you go for renogram, or you uh, will show the renal function.
Yeah, so you asked a lot of valid questions, Dr. Basan. So basically, our follow-up protocol is like this. We get an ultrasound at 3 months from the time of stent removal. So we remove a stent by the time itself 2 months has passed. Then we wait for another 3 months, so it's already 5 months from the time of pyeloplasty when we get an ultrasound. And then we get a renogram after another 3 months if the things are going in the right direction. Now, if the pelvis is getting increasingly more, for example, this is something which I have to warn the youngsters because when the pelvis is not coming down by around some 10 to 15% at least, or if the patient is having pain or infection, then there is a real indication to do an ultrasound and renogram earlier because one cannot simply reassure patients without having an evidence that things are going in the right direction. But if the pelvis is coming down slowly, at least some 15% reduction by 3 months and then 20% reduction by 6 months, then it is good enough. So 20% reduction by 6 months means like 40 millimeter pelvis will become like 30 millimeter pelvis. That is good. That is actually good reduction. And then by 1 year it will become like 25 millimeter, then it will take some time. Similarly, the cortex also will increase from 1 millimeter thickness to 3 millimeter to 5 millimeter. So it will take roughly around a year at least to start any significant reasonable changes. Yeah, so that's what I mean. It takes at least 1 year to see some visible changes in both
Yes,
the
yes, sir.
function.
I
Yeah,
have seen this article. It
yeah.
was written more than 6 months. That's why I have
Yes,
asked it.
correct,
But in
correct.
6 months, it's very difficult to find the changes in
Yes,
the renal
yes,
pelvis.
I totally agree. Yeah, it
And
takes at least 1 year. Yeah,
yes, sir. My last question is that, sir, that is very nice article, and it is the first, I think, meta-analysis and systemic. So, how will you rate it? What is the strength of your study? Hmm?
yeah.
What you
I
think,
told my
what we should do by this
I've
study?
told myself any meta-analysis based on the quality of the articles which are included, and here 4 articles are not already very good. So so we have to take it with a pinch of salt. When we don't have the evidence, we have to produce evidence. So I suggest everybody to come out with a large series of reduction versus non-reduction pyeloplasties, and then publish their results so that at least 5 years down the line we have more robust data.
Okay,
Now
thank you,
we
sir.
think that we have a feeling that we cannot repeat a study, we cannot repeat an article. This is the thing. See, this Enono Yoshu has done a study recently and published in JAPS. And when he looked at it, that is the largest series, for heaven's sake. I mean, although she has repeated something which has been done, the previous studies are of very poor quality. So if we are going to repeat another study with 40 patients in each limb, it is definitely worthwhile doing for a PG. So we have to look at it like we are producing new evidence and extra evidence to either counter or support the same thing.
Yes, sir. Fully agree with you, sir. We are doing a lot of pyeloplasties, both by
Yes.
open lap and robotic, but
Yeah.
still we are lacking. That is,
Yeah.
we need to look for that. Over to Rahul.
So I think we should proceed to the next
Thank you. Thank
presentation, sir. Thank you, sir. Dr. Rohit, are you ready? Dr. Rohit, are you ready with the presentation? You can start.
Good evening, everyone. I'm Dr. Rohit Lal, Senior Resident from Department of Pediatric Surgery, IJMS, Patna. I'm presenting on the topic association of sacral index, sacral ratio, and sacral curvature with different types of male anorectal malformation. Anorectal malformation are characterized by developmental anomalies in the distal segment of intestine, resulting in absence of malformed anal orifice. ARM was classified into low, intermediate, and high on the basis of spread classification. The incidence of ARM is 2 to 2.5 per 10,000 lab newborn, with gender ratio sinks between 55 to 70% in favor of boys. SR is currently the only measurement to quantitatively evaluate sacral development. This study proposes sacral curvature and sacral index as a new indicator to assess quantitatively and qualitatively sacral development and level of ARM. Low ARM is associated with good prognosis and outcome in comparison to intermediate and high ARM, and sacrum will be well developed in cases of low ARM patients. To differentiate, the purpose of the study was to differentiate intermediate and high ARM from low ARM. SR was an important parameter. However, low ARM can be differentiated from others by clinical examination alone. SR alone has little role to play to differentiate intermediate ARM from high ARM, and to differentiate intermediate from high ARM need for other parameter field. Aim of the study was to determine the association of between sacral index, sacral ratio, and sacral curvature with different types of male anorectal malformation and its correlation with the level of recto-urinary fistula at surgery. The objective of the study were to measure and compare the values of sacral index, sacral ratio, and sacral curvature in different types of ARM with the help of X-ray, and to assess the position of fistula and rectal pouch at the surgery and correlate them with the values of sacral index, sacral ratio, and sacral curvature, and to determine the role of sacral index, ratio, and curvature in assessing sacral development in cases of anorectal malformation. Methodology, inclusion criteria. All the patients of male ARM who would present to Department of Pediatric Surgery IMS Patna for management during the study period for primary or staged surgery. ARM patients with neonatal radiological assessment. The exclusion criteria were cases where radiological X-ray would be suboptimal, inadequate, or not appropriately centered to measure the sacral parameters. ARM patient without neonatal radiographs presenting for second or third stage, parents not willing to contribute to the study, and all the ARM patient without fistula would be excluded from the study. It was a prospective study. Sample size was 63, 21 in each group, that is low, intermediate, and high. The study period was from October 2022 to April 2024. PCTL, that is prone cross-table lateral radiograph, was done to assess rectal pouch gas shadow. Infantogram was done. Sacral index ratio and curvature was assessed through PCTL and infantogram. Surgical details like approach to surgery, position of the rectal pouch, and fistula was also recorded. And paired t-test, one-way ANOVA, Carl-Pearson coefficient, and ROC curve analysis were done using MedCalc statistical software version 23. These are the radiographs of PCTL radiographs of ARM and the infantogram of the ARM patient. This is the figure depicting the calculation of sacral ratio, curvature, and sacral index. And below is the geometry for the sagitta calculation. It can be helpful in measuring of sacral curvature. The results, sacral index was more in high ARM than the low ARM. The p-value was significant for low versus intermediate, low versus high, and high versus intermediate. Sacral ratio was more in low ARM and low in high ARM. The p-value was also significant for low versus intermediate, low versus high, and intermediate versus high. Sacral curvature was also high for the low ARM and low for the high ARM with significant p-values. Below is the table for difference for the levels of sacral index ratio and curvature for rectoprostatic fistula and rectobladder neck fistula with a non-significant p-value. This is the box and whisker plot showing a significant p-value for sacral index ratio and curvature for the different types of ARM patients. This is the ROC curve analysis for differentiation of intermediate and high anorectal malformation from low anorectal malformation. The area under curve was more for the sacral ratio with a value of 0.9195, followed by the area under curve of sacral curvature with a value of 0.8282. And the area under curve was least for sacral index with a value of 0.8152. This is the ROC curve analysis for differentiation of intermediate from high ARM. The area under curve was more for sacral index with a value of 0.8628, followed by the area under curve of sacral curvature of value 0.8571, followed by area under curve for sacral ratio with value of 0.7891. This is the Carl-Pearson coefficient table, which shows inversely relationship between sacral index to sacral ratio and sacral curvature with a significant p-value. The relationship between sacral curvature and sacral ratio was proportional with a significant p-value. There is an intimate relationship between the development of sacrum and the levator ani and the sphincter muscle complex formation with the level of ARM. In the present study, male ARM were taken into study which favors the global trend. The mean value found in normal children with appropriate lateral and AP sacral ratio represents 0.74 and 0.77. Individual possessing a sacral ratio below 0.50, however, have a markedly lower likelihood of regular function. Chen et al. In 2021 hypothesized that sacral curvature along with the sacral ratio, should be evaluated when assessing sacral development in ARM. The present studies support this view by demonstrating a significant correlation between sacral index and sacral curvature with the types of anorectal malformation. Conclusion. Sacral index, ratio, and curvature have a significant association between low, intermediate, and high anorectal malformation. Sacral ratio was more specific to distinguish between low ARM and intermediate or high ARM. Sacral index was more specific to distinguish between intermediate and high ARM. This parameter can play a vital role in deciding primary PSARP or APPT in the management of intermediate and high ARM in male babies. Thank you, sir.
Very nicely presented, Dr. Rohit. And I will congratulate you for publishing a new indicator, sacral index, for qualitative assessment of the sacraments, and a very nice statistical evaluation. There are a few questions which I would like to ask you. And regarding the methodology in the chronological order, can you explain the methodology in the chronological order? That is, what radiographs were taken for sacral assessment, like other than PLTC and infantograms, their views, frequency, whether they were digital or non-digital, and what was the size of the films, and how you done the measurements.
Measurements, the radiographs were digital radiographs. The size was 12 by 18-inch film, that the regular film. The X-ray was photograph was taken, and it was converted to PDF, and printout was taken on the paper, and it was calculated by using a scale.
Okay. So what was the measurements done after the assessment of the type of ARM or before the assessment of the type of ARM to go remove the observer bias? How it was done?
Few patients came in the neonate period. Sacral ratio, curvature index were measured during that period, and they were followed up, and the OT findings were recorded later on and was correlated. And for few patients came for second or third stage, the radiographs which were taken in the neonatal period was assessed.
Thank you, Dr. Rohit. There's one more question. And why have you excluded female patients and patients without fistula in your study? Was it related to the fistula or something else you had in your mind before excluding such patients, specifically female patients? Or it was only for the male ARM?
It was for male ARM patients. Actually, female came late. They present late by second, third.
Yeah, this is observed in most of the centers that female vestibular fistula usually present late to us.
Sir, can I add something?
Yes, you can add, sir.
So many a times female patients, they presented late, and that's why they were not included in this study. And we wanted to have uniformity across all the groups. And because this differentiation in the fistula level, particularly, we can observe in male patients only. That is why in this study, we included the male patients only to ensure uniformity in our observations.
Yes, Sandeep. Sandeep, you are here. Please don't go. Actually, my question is that why you excluded these without fistula patient? What is the rationale about that?
Sir, actually, sir, without fistula patients, sir, actually, particularly if they are Downs patients, only then we most of the times get without fistula patients, sir. And whatever previously we saw, sir, we actually had most of the patients who presented with the fistula, sir. So actually, that group we did not include because we actually that group we did not expect that those many patients
would be including in the study, sir?
No, Sandeep. Actually, we are going to do a something ratio or something that is permanent. I think.
Sir, actually, sir, we depending upon our sir experience, sir, we expected that we would have sufficient number of patients of low, intermediate, and higher type, and we would not have that many patients without fistula, sir. Therefore,
Okay.
for the and it was a thesis for the PG, sir. That is why we said that
Okay.
it should be time bound. That therefore we restricted ourselves to these
Yes.
groups only, sir.
Yeah. This is acceptable.
Uh,
Yeah, Rohit.
we would be doing a larger study, sir. We will be including patients with fistula because we don't have that many number of without fistula patients at our center, sir. Now that actually I
Okay.
have come from that center, but we'll be including that also, sir.
Okay. Okay.
Excuse me, sir. May I add
So
something?
can
Excuse me, sir.
yeah.
I'm Dr. Vinit. May I add something, sir?
Yes, Vineet. Yeah,
Yes,
please.
sir. Actually, the purpose of this study was at our center we started doing primary PSRP. So on most of the occasion we were confused whether we should go by APPT or primary PSRP. For that need of this invertogram and the ratio of sacral curvature came into place. So even the patient who came for second stage surgery, we asked for neonatal X-ray only. Female patient mostly come with low RM and we do it primarily by primary PSR. So that was not confusion. And without fistula, as Sandeep suggested, that few fistula patients can be Down syndrome. Patient was not, so we decided that we should exclude this study. Our
Oh,
aim was to just to localize rectoprostatic and rectoverbal fistula, and whether we would be able to do it by primary approach or by APPT approach.
yes, Vineet. Actually, yeah, I agree. Whatever you did, but if you are here, so I want to ask. In whole article, what I have read, he has said कि you want to localize the fistula by these index, but it was not written in this article. You have probably you have seen it. कि what is the relation of fistula with relation to sacral index or sacral curvature or sacral ratio? It was not written in whole article, I think.
Actually, it was prepared from thesis, sir. He might have missed that results, but he has
Okay.
correlated with this thing.
Uh,
He has correlated in thesis. He has
yeah,
correlated.
yeah. Vineet, I know. I have reviewed this thesis.
Might have
Uh,
missed in the paper.
Okay. So Rohit, please come to your article. You have told that, and don't afraid to my any question or anyone's questions. You have to free to answer. Let me know what kind of study is this.
It is a prospective study.
Yeah, definitely prospective study. Then please sub classify. Actually, there is a lot of statics in this article. Even I don't understand that. But I am asking very simple question. It is a prospective study. It is case control study or quality study. What level of evidence? Do you know?
It is a case control. Low ARM was taken as control.
Yes.
Case control study. Okay. And do you know about level of evidence?
Sorry, sir, not getting.
Okay. That's okay. Rahul, up to you.
Sir, related to this, the discussion going on, just wanted to know what was the incidence of sacred anomalies in your study as per the subtypes also, if you can answer. Dr. Rohit, can you answer what was the incidence of sacred anomalies based on the type of the defect, that is high, intermediate, or AM? Was it also part of the study or not?
No, it was not the part of the study.
Okay.
But I have data of the previous year
Okay.
during the study period. 140, around 140 of the patients were admitted, and 20% were having, around 20% were having vertebral anomalies.
Okay. So you have written in your manuscript that it is the incidence of sacral anomalies and ARM is roughly around 30%. So
Yes.
you must be expecting a higher percentage in high type and low percentage in low type.
Yes.
Any additional findings in your study, which after your thesis completion, you must have noted in these patients, ARM patients, as far as the sacral anomalies is concerned? Just for the knowledge of all the junior people, the residents also. Any additional finding you have noted or not?
No, sir, not apart from sacral index and curvature.
Okay. Very nice, Dr. Rohit. You have done a new index. You presented a new index.
Yeah,
And
Rahul, can I ask one more
yes, sir. Yes,
question?
sir. Please, sir.
Sir, can I say one thing, sir?
Yes, yes,
Sir, it
Sandeep.
was actually it was a prospective cohort study, sir, and the cohort was the different level of patients which we followed from initial level when they were admitted to they were operated, sir. So it was a prospective cohort study.
Yes. Although, Rohit, you have mentioned that you have not followed up for long term. It is this study was only 18 months, so you don't
Yes.
correlate these findings with outcome. Actually, sacral ratio has a wider ROC plot in your ROC curve. So that's why ROC is used. Do you think this sacral index and sacral curvature, this is the first time you are mentioning that?
There are paper on sacral curvature.
Okay.
Sir, sir,
20.
can
No,
there is
Sandeep, not you. Rohit, please tell.
Uh, So, Chen et al. 2021, he published a paper on sacral ratio and sacral curvature.
Okay.
But sacral index is new, sir.
Sacral and is new. Definitely it is new. Yeah, well done. Rohit, Rahul, up to you.
I think, sir, we should step into next presentation by Dr. Sugant Chadha. Dr. Sugant, you can start.
Yes, I'll just play my screen. Yes. Good evening, everyone. I'm Sugan, currently working in Singapore as a clinical associate. This study was conceptualized and performed under the guidance of Dr. Lakshmi from Child Stress Hospital, Chennai. It is the title of the study is Navigating Ergonomic Challenges in Pediatric Laparoscopy: Insights from Indian Surgeons. So coming to ergonomics is the study of efficiency of a person in their working environment. In surgery, it refers to placing the equipments and using instruments in a way that it aids in the smooth performance of surgeries, avoidance of injuries, and reduction of fatigue. Laparoscopic surgery is also an acquired skill, and it has a long learning curve, as we can see. Um, if we perform the surgeries based on the correct ergonomics, it helps minimize fatigue that results in reduced procedure duration, margin of error, and also reduces the rate of conversion to open surgery, especially in advanced laparoscopic procedures. There have been few studies done previously that have mentioned the ergonomic problems associated with laparoscopic surgery, but no such study has been done in India to assess the challenges that pediatric laparoscopic surgeons face in India based on the monitor height, position, and the surgeon's variability, like the experience, height, gender. The aim of the study is to assess the awareness and identify the issues faced by pediatric surgeons in India in terms of laparoscopic ergonomics. This was a prospective study performed in 2023 by circulating an online questionnaire with few questions regarding laparoscopic ergonomics and difficulties faced by the surgeons. The study population were Indian pediatric surgical consultants and trainees. The data was later analyzed and classified. This is the summarized questionnaire. It included 18 questions that were age, gender, height of the surgeon, experience of the surgeons, level of the laparoscopic surgery performed, the musculoskeletal discomfort faced, and if faced, what kind of discomfort was it, the height of the monitor from the level of the eye, angle at the elbow while performing the surgeries, if ergonomic principles were neglected at the workplace of the surgeon, and if the management supported the surgeons by providing the adequate infrastructure and instrumentation as per the child anatomy. So this is a picture demonstrating incorrect ergonomics while performing a vesicoscopic reimplantation surgery. As we can see, the monitor position is above the angle of the gaze of the surgeon, and also due to the broad, wide operating theater, the surgeon has to abduct the arms to overcome the angulation. Coming to results, we had 152 pediatric surgical consultants and trainees who responded to the questionnaires, out of which 30% faced discomfort. Discomfort was mainly reported by 49% surgeons belonging to age between 35 to 50, and it was also noted commonly in the senior consultants. That was 47%. The discomfort ranged from neck and shoulder pain to fatigue, generalized discomfort, finger pain, and some of the surgeons also had a neural injury, that they had like chronic pain in their wrist and fingers. We had 120 male respondents, out of which 31% faced discomfort, and 32 female respondents, out of which almost 50% faced discomfort. Discomfort was most commonly noted in age above 60 years, that was 58%. And it was also noted in 41% of senior consultants and 40% of senior postgraduate trainees. When we correlated the height of the surgeon with the gender, we noted that the height of between 155 to 175 centimeter noted most discomfort, and the height less than 155 centimeter in male resulted in like 100% and 79% discomfort in female surgeons. Correlating the same with monitor height, we noted that the surgeons who placed the monitor above the level of their eye had most discomfort. Overall, it was 45%. When we correlated this to the height of the surgeon, we noted in height of more than 175%. If they placed it below the level of the eye, they had most discomfort. Between the height of 155 to 175 and less than 155, if they place the monitors below the level of the above the level of the eye, they face most discomfort. When we related the study discomfort to the level of laparoscopy, advanced procedures, surgeons performing those advanced procedures had most discomfort, and those who abducted the arm while performing the surgery also reported significant discomfort, that was almost 61%. We further did statistical correlations to find the level of discomfort to surgeons' experience, age, height, gender, and monitor. And our inference was that only surgeons' height had a positive correlation to discomfort, and gender had a borderline positive significance, but only 21% women respondents were there in the study. So we could not derive a conclusion on this. 93 surgeons noted that principles of ergonomics were regularly ignored at their center, and out of this, 55% reported discomfort, and 66 surgeons reported that their hospital management ignored demand for necessary infrastructure to attain good laparoscopic ergonomic goals. And we also noted that surgeons aged more than 60 years had more discomfort that could be either due to age-related inflexibility or cumulative effect of performing longer procedures and more complex surgeries. Height of the surgeon, as we noted, had a major correlation to discomfort. This could be due to the monitor height being above the level of the surgeon's eye, and also the instrument length being shorter and larger, making the surgeon abduct the arm more to overcome the angulation. I would like to conclude the study. We noted in conclusion that height of the surgeon had a positive correlation. Increased age had a higher percentage of discomfort, and 55% surgeons who faced discomfort felt that the principles of ergonomics were neglected at their hospital, and 35% surgeons reported lack of support from hospital management to provide the necessary infrastructure. We also noted that there should be a follow-up study with the glove size of the surgeon to the instrument length ratio to note the discomfort while performing surgeries, and increasing the study strength would help us derive more positive correlations with the larger group of surgeons. The take-home message from the study was that we need to respect the ergonomic principles to achieve the best results and reduce fatigue, as that would help increase the longevity of a surgeon's career. The trainees need proper education about the ergonomics, and new surgeons or previous old surgeons who face these injuries can go for haptic feedbacks to retrain for the laparoscopic principles. A few take-home messages are the things that can help a surgeon perform surgeries properly is ventilated and quiet operation theater with a dim light, appropriate glove and footwear and scrub size that avoids tripping, following the laparoscopic principles of angle of manipulation, azimuth angle and elevation angle, having operating theater table that can go to height as low as 65 to 90 centimeter above the ground, and narrower table should be used for smaller children and neonates. Placing the monitor below the surgeon's gaze, at least 15-degree inferior, that helps reduce the strain on the neck, and using another monitor for the assistant. And instead of just of standing in a stationary position during surgery, the surgeon should keep moving their arms, leg, and hand, and take mini breaks every 20 minutes for like 30 seconds. And while performing long surgeries, the surgeries can be done in teams, allowing the other surgeons to take short breaks. And surgeons who report discomfort can retrain ergonomic principles by practicing on haptic feedback models. These are my references. This is a study that was done showing retraining of the surgeons with using haptic feedback model. Thank you.
Very nice presentation, very nice slides, Dr. Sugan. And I congratulate you for being the first ones for publishing the challenges, ergonomic challenges, which are faced by Indian pediatric surgeons. And just one question. How many similar studies on overseas surgeons and especially pediatric laparoscopic surgeons you have reviewed or browsed for preparing this questionnaire? And second part of the question is, what was the most important survey question or questions among the 18 you have uh, uh, described?
Yeah, thank you. So while going through the literature, the recent studies we noted, there have been few studies done in Europe that also noted about the ergonomic challenges faced by the surgeons, but none of those explored the surgeon's variability, like the height of the surgeon, the gender of the surgeon, the position of the monitor based as per the surgeon's gaze of vision. And so this is the only study that we explored all these issues, because we noted that all these issues play an important part in helping the surgeon reduce the injuries and fatigue. And out of all the questions that we had, the important questions were injuries, what injuries they had, and the monitor position based on the surgeon's gaze of vision. Because we noted that most of the surgeons who placed the monitors above their eye faced some neck pain, shoulder pain during the surgeries.
Cool. Can I go?
Yes, sir.
Yeah, Sugandh. Very nice presentation, and I respect Lakshmi sir. But I think you are resident or you are faculty.
Sir, Dr. Sugandhi is working as a clinical associate in the Department of Pediatric Surgery at KK Women's and Children Hospital, Singapore.
Okay. So he is not resident. So just I want to ask, it is a if I say it is just replication of previous published articles, what you say? What is new in this study?
When I was exploring all the previous articles, we were looking at the old papers to formulate a questionnaire. So we did not notice any article that explored the surgeon's variability and also the monitor position in the studies. The most common things that they noted were the length of the instruments, the table length, and but none of these studies we noted had
No.
explored this.
Yeah, I agree. Many things are new in this article. But what you think? What is the drawback of this study? Major drawback.
Or the limitations in this study?
One of the limitation that we noted was like very few surgeons filled up the questionnaire. So our study sample size was very small to derive a conclusive
Why they
outcome.
feel less? Yeah, you have written, you have taken this questionnaire in the social forum only for 2 months. Why not 6 months? If you are taking for 500 person, you are distributing something in 500% and only 150 and only 36%, 36% person is responding. So why we should not wait? Or how many times you circulated that survey?
It was circulated almost daily over all the platforms. But the thing was, we had a deadline because we were submitting this article for an international conference. So we had a
Yes,
deadline to submit the abstract.
agreed. But can you tell about why person are not responding? If you are sent in 500 pupil, if you have sent 500 pupils and only responding 36%, what are the reasons? IAPS a very active group. What do you think about that? Why they are not responding?
I'm not sure. Maybe the questionnaires were like had a lot of questions and
There is lot of only 14 question are there. I am
like
not agree with question number 14. You are written, are you aware of a strategy of reducing strain and fatigue during laparoscopic surgery? I think any person who is going to for laparoscopic surgery, they usually go for initial, so they know about what is the role of micro breaks, exercise and targeted stretching. So
but
do you ask any person ki how many they do it or not?
surprisingly, in the answer, almost 40% people they said they are not aware of these strategies of how to reduce strain.
Then IAPS role is bigger. Okay.
There's one more question, Dr. Sugan. You have mentioned in the introduction that surgeons' demographics and patients' body habitus was evaluated. Did you evaluate about BMI of the surgeon also? It may have bearing on the.
No, we did not evaluate.
Okay.
Yes. One more thing, Sugandh, you have forgot to telling about what a newly surgeon want to need to do. If height is less than 150, 155, you cannot lower the operating table. You cannot lower that your monitor. But is there any mean by which height can be raised?
They can stand on a stool, but the stool should be high enough so that they can have a
Not
angle.
not not in stool. It is wooden
Uh,
board.
wooden
It should
yes,
be wide enough.
yes.
कि surgeon should
Wide
not
enough to
fall.
remove.
Okay. Thank you.
Dr. Sugan, there's one more question. In the study, you have mentioned that 36% out of 152 laparoscopic surgeons, there were ergonomic related in discomforts and injuries. So, like, were there any overlap of symptoms, or none had overlap of symptoms? You have described four types of symptoms in your study.
Few of the surgeons had multiple injuries. They reported they had shoulder pain, arm pain, wrist pain. So few of them had multiple injury, but most of them had shoulder and neck discomfort.
Okay. So, are there any other recommendations that you have want to suggest other than the ones which you have published? Your personal experiences or experiences of your mentor men?
I feel like as a new surgeon, I am very stiff when I operate and I don't move my neck or my arm a lot. And I also sometimes hesitate in asking the other surgeon to adjust the height of the monitor or the table height. So probably these are the most common things that we need to look into, that we should be like more relaxed and take micro breaks, move our arm and wrist so that we don't face strains in the neck and the shoulder.
Very nice presentation, Dr. Sugan. Dr. Vijay, are you there?
Can I just say a couple of words in this?
Yes, please.
Yeah. So the reason we started this survey and we talked about it is, first of all, within India, I find most of the time the monitor height is fixed. We don't have the monitors on swivels in most of the centers, and the stack that is manufactured in India, or which is given to us from most of these, along with these stacks, they all place the monitor at a very high level. And in fact, when we were buying monitors and stacks in our own hospital, I had to, go to great lengths to try and negotiate so that we can get a monitor with a stack which is of a shorter height. I mean, I'm a very short surgeon myself. And as Sugan knows, I always stand on a platform to operate on all of these kind of patients. But in spite of that, the monitor height is very, very, very much above the eye level.
Hello.
And it will be above the eye level for most of the other surgeons too. So that's where the thing started. But then when we were looking into the various ergonomics, I realized that surgeon variables have not been looked at in none of the studies which have been published on this subject internationally or in our country also. So that was one of the things that we were looking at particularly here. And I think ergonomics is being looked at more seriously nowadays because people are already facing problems. But when we were undertaking the study, I must say that a lot of people didn't know that you can actually make things better by following certain principles and taking a short break, or and it's not only that. I think most laparoscopic surgeons, they actually have to do a lot of exercise and keep themselves more fit so that they will have less injury during work. So it's a combination of different factors that led us to do the study there.
Thank you, ma'am, for your key points. Any questions? Dr. Vijay, are you there?
Yes, please. Yes.
Only comment. I think this study reinforces what is known. Means everyone knows whatever is the inference of laparoscopy surgery, the problems faced, and how you can overcome. Very nice study anyway. Thank you.
Thank you.
Yeah. So again, thank you, moderators. I mean, you were asking for Vijay, but I am taking over.
Thank you,
you,
sir.
moderators Rahul Gupta and Basant Kumar, for nicely moderating the session, as well as all the speakers, presenters, and their mentors. All three papers were wonderful, and I think all of us have enjoyed the presentation. So once again, I thank you all. I request uh, Dr. Basant, Dr. Rahul Gupta, Secretary IAPS, and President, if he is present, to be around. Everybody else can log out of the screen. We will select the best paper which is presented today. Vijay, you can make me host and you can also log out.
Sir.
Thank you. Thank you,
Yes,
everybody.
sir. Change host. Okay. Done, sir.
Yeah. Thank you. Thank you, everyone.
Thank you, sir.